Dr. Ball on? That's fine too. So remember the midterm is from the very first lecture up until the CNS 3-1, number 10. Right to the end where we talk about cerebellum, and that's where it stops. So there's nothing on the midterm about vision and on. Okay? I think that's already been posted on the course shell, but I still had questions. Even though it's in writing. So, yeah, go ahead.
Can we start off with the circle of Willis?
The circle of Willis. Of course we can. That's where we often get a lot of questions. So 4 big vessels supply blood to the circle of Willis. So there's 2 internal carotids, right, left and right, and then there's 2 vertebral arteries that they come right off the subclavian. It's one of the early branches off the aortic arch. But then notice that those vertebrals, they're actually running through the bony processes of the vertebrae in the cervical region. That's the only place where you find blood vessels running through your vertebrae. So what's really interesting, we didn't talk about this year, but if you think about, when you get chiropractic manipulation, you get your neck kinked around. Well, for individuals who have really advanced atherosclerosis happening in those vessels, guess what could happen? Some of those plaques can actually break off the vessel wall and start floating around up to the circle of Willis and your cerebral arteries. So just keep that in mind. Nothing comes without risk. Anyways, 4 vessels, right, supplying the circle of Willis. Remember these 2 vertebrals, they come up, but they then combine together to form that basilar artery, which you can find on the ventral surface of the brain stem. It's just that one blood vessel that runs up there. What's the importance of the circle of Willis? So you can see the circles formed right here, right at the base of the brain. So all the blood supplying the brain tissue itself comes from the bottom, gets squished through the brain, and then it gets drained away by veins on the top of your brain. Remember, they dump into that big sinus between the falx cerebri. So that's what it looks like from the inferior surface of the brain. Notice that this circle of Willis forms right around the pituitary stalk. So it's kind of the center of your brain. This is where you would have cut the sheep's brain when you did that dissection for the frontal plane, right through the pituitary. So it's a circle. We've got 4 blood vessels coming in, 2 vertebrals, 2 carotids. Remember, the vertebrals come together to form the basilar. But the whole point is it's like a traffic circle, like the one we have just down here, that way. Okay? So cars can enter, blood can enter this circle and go round and round in any direction it likes, as long as the pressure pushes it in that direction, right? So if we had, for example, a blood clot and one of those vessels in that circle, it's not a problem. Because if there were a blood clot here, blood could still come into the circle and get out through the cerebral artery to supply the brain from this side or from that side, just being pushed by the pressures generated by the heart. So that's why we say that the circle of Willis helps to minimize the consequence of a stroke. The problem is, once you're out of the traffic circle, there's only one road to take to get to that part of the brain, right? So for the lateral aspect of your hemisphere there, it's only this road you can take, the middle cerebral artery. So if you get a blood clot that occurs after the circle, once the blood has come out of the circle to get into the cerebral artery, that's a problem. That's when you have functional deficits. When you affect certain regions of the brain that are responsible for doing certain tasks, right? Did that address it? Mostly? Right, so that's what we mean by before the circle, everything's fine. So we have people that live with those 2 internal carotid arteries, very full of plaques, atherosclerotic plaques, very little blood getting up through them. But because there's 1, 2, 3, 4 vessels supplying that circle of Willis, you could theoretically knock 4 of those out and still have just enough blood pressure to keep blood flowing through the circle and flowing to your brain. So that's what they were saying when it minimizes the consequence of the stroke. Okay. That's what it looks like pictorially. So we call this an anastomosis when arteries connect up with other arteries to form this, form what we consider, you could also call this collateral circulations, because the blood can take more than one route to get to, for example, that middle cerebral artery or that posterior cerebral. Because it could come from, the internal carotid here to get to the posterior cerebral, or it can come up from here, or from this side to get into that posterior cerebral. So that's the definition of an anastomosis, when you have more than one route for blood flow to go.
So like for that slide underneath the circle of Willis, you know how we have the anterior cerebral artery, and then like what's gonna happen if it gets blocked?
Mm-hmm.
How do we know, like say for the internal carotid artery, how do we know what the effects are gonna be if that was blocked?
Internal carotid.
Or like any of the other arteries that's not the cerebral?
So you shouldn't worry about that, right? Because if it's here in the internal carotid or a vertebral artery, that's before the circle. So that clot has little effect on your brain because of this traffic circle. You can knock out this road, but blood is still coming in here, here, and here, supplying enough to your brain for all the regions.
So just if it was, say, the interior, or the one at the top, then that would cause great effect then?
Yeah, so if it was this one here, for example, the left anterior cerebral artery, yeah. It would deflect blood flow to the left side of the hemisphere, right? In the discrete region that's actually supplied by that artery. Which you have a little diagram that shows you where that blood goes, right? So there's 3 different colors in that diagram. This isn't the best, they've swapped this picture out from last year. Thinking about just the cortical surface, that's what the anterior cerebral artery is doing, that pinkish area there, which really represents, if you look at your hemispheres, remember there's a huge fissure, a groove between the 2 hemispheres. It's doing all that medial aspect of your hemisphere. You can't see it from the side because that's a lateral view. This is why they show it this way. This is the medial view of your right hemisphere. So this is the middle part of the right hemisphere that you can see here. That's the anterior cerebral artery supplying all that region there. So it supplies, remember that cingulate gyrus, your reality checker when you're making memories. Is this something I'm dreaming up, or is this something that really happened to me? That's there. Plus, if you look back at your homunculus, remember the little guy that's curled over your cortex? The homunculus, what region is right here on the middle part of your cerebellum? We go back to him. Where is he? He's not in this one, right? He's in the next one. You have to put information from more than one slide set together to answer those functional deficit questions. So where's the homunculus? There he is. So if this is the middle part of your cortex, right? This is where the falx cerebri is, separating left from right. This region is supplied by the anterior cerebral artery. All this region here by the middle cerebral, because it does the sides of your cortex, right? If you knocked out the anterior cerebral artery, what part of your body would you expect to see difficulties with motor and sensations? The lower part of your body, right? Lower limb, hip region. See how the hip is up here? All of this is being covered. You might even get some of the trunk involved. If it was the middle cerebral artery, you expect your deficits, both sensory and motor, to be in this region of the body, right? Upper limb, head and face. So when you get these problems, first thing I would start with is it left or right side of the brain? So look at the symptoms. Remember, Left side of the brain receives all the sensations from the right side of the body. It is also responsible for controlling all the muscles on the right side of the body. So I would start there. Is the sidedness correct in the options in the question? Yeah?
There was one part in the lecture, I don't know if it was the last or not, but where there's an exception where the left does equal the left and the right does equal the right. Is that with vision? The cerebellum?
Only the cerebellum works that way. It works in what we say is an ipsilateral fashion. So ipsi means same side. It's not contralateral, like your hemispheres. Yep.
There was a question I had on a quiz online, and it said if you had a lesion to your primary motor cortex, like what would the result be? And like I said, an inability to initiate movement, but the answer was loss of fine but not gross movement. So why is it only fine? and
That's
not
an interesting question. I don't remember that one being in the bank.
Okay, I was just
It's a
wondering.
Dr. Ball question. So if it's primary motor cortex, that's that area there, which is responsible for directly sending the signal out to your skeletal muscle. If you want to initiate a movement, you can use your
that's a fine.
prefrontal cortex, right?
Yeah.
Your basal ganglia sitting in here can also help manipulate voluntary motor movements. And same with your cerebellum. It helps you find control some. Right? That was a tricky question.
Yeah, it was.
Yeah. I'll have to look up the exact wording for that one.
Okay.
There was probably something in there that was very obvious. Well, maybe not.
Sorry, so for the cerebellum, like,
Sorry, go ahead, yeah?
oh no, you can go.
No, we're finished.
Oh, okay. Okay, so for the cerebellum, like how it's ipsilateral, so then how the difference between the axial and the appendicular. So the axial receives it from like proprioception, is that why it's only single crossed?
Yeah. Let's go back to that slide. It's really warm in this corner. There's lots of sun coming through here. It's warm in this room, period. Too bad the windows don't open. That's to prevent us from jumping out of the windows. Because, you know, we just might decide to do that one. The big thing to remember with the cerebellum is the fact that the sides of the cerebellum, the lateral parts, are responsible for controlling muscles that are, you know, kind of away from your body, so your lower limb and your upper limb, the appendicular skeleton, whereas the middle parts of the cerebellum are responsible for coordinating movements that are associated with your axial skeleton. So everything right on the midline. So this would include, if you think about the midline, it's a lot of muscles involved in posture, keeping you standing up straight, and muscles involved in balance, keeping you from falling over, which is what we're constantly doing when we're standing on 2 feet. We're making a bunch of corrections. The cerebellum mostly taking care of that for us on a subconscious level because we're not aware of it. But it's contracting those muscles as we sway to the side, you know, back, front. It's correcting all of that. So, because that middle part of the cerebellum is responsible for balance, so that's the middle part there. Remember, there's a left and a right side to that as well. So, the right side of the middle part of the cerebellum is controlling all those muscles of posture and balance on your axial skeleton on the right side of the body, on the same side. But because this is involved in things that you don't put a lot of conscious thought into, it's automatic, not autonomic, but automatic. There's not really a big need for your cerebral cortex to consciously be controlling those muscles as you're standing up and holding yourself straight. You're letting the cerebellum do most of that work. So because the cerebellum's doing that, it wants to be able to communicate quickly, so it stays on that side. Most of the information. Just a little bit of the information obviously is being shared with the opposite cerebral hemisphere because remember, left controls right side of the body, and you can change your posture. You can be, you know, a little more cognizant of wanting to stand up a little straighter, or maybe flexing your body, you can do that obviously voluntarily, right? So you override the cerebellum, although you're not really overriding it, you're just asking it for instructions on how to do it correctly. Yeah. So this is what they said was the single cross pathway, because largely cerebellum's just doing most of the work for you. So what's on the one side, it only has to stay on the one side, the information. But if you're doing something fine like writing, waving to someone, that's your appendicular skeleton. You're making that conscious effort to make that movement. So this this cortex is going to call over to the opposite cerebellum to say, okay, I want to wave, but how is it best to do that? Because I have no idea where my arm is in space right now. Is it beside my hand, beside my body? Is it already raised? What's going on? Cerebellum knows about that because it has 3 pieces of information. Yeah, proprioceptive is one, so position sense. It knows what angle all your joints are at, and it can compute where your limbs are in space. It's got, both of them begin with a V now. Vestibular, which is balance from your inner ear to tell you whether or not your head is tilted with respect to gravity, whether you're moving forward, sideways, or up and down through space. All of that's being told by your inner ear. And of course, the last one is, begins with a V again. Vision. Everything you see and you process in your occipital cortex for you to enjoy the world, well, the cerebellum is being fed the same information from your eyeball. You just don't know about it because it's subconscious. It's using that visual information to be able to see, hey, the object, for example, you want to pick up off the table, it's there. Where's your arm in relation to that object? Well, your cerebellum can see it. It's got a black and white TV that sees your limbs as it's making movements, which is really scary. But that's what it's doing with that stuff. Okay? So for the appendicular skeleton, we say it's a double cross system because many times when you're manipulating your appendicular skeleton, it's because you're doing something that's different other than trying to stand up straight and not fall over. It's like you trying to move somewhere, navigate around objects, maybe pick something up from the table, steer your car, whatever. You're making an actual conscious effort to move those muscles. So you got to talk to the opposite cerebellum because this cerebellum on the right side is controlling the right side of your body. Well, helping not to control, but to coordinate those muscle movements. Because it has all that information. And it knows how best to do it. Does that answer?
So if it says single cross, that means it doesn't cross at all, right? Or
It's implying that the cerebellum is doing most of the work automatically, just maintaining muscle tone and balance, so that the information is staying on the one side.
Okay.
Yeah. And it's kind of weird if you think about it. The next lecture that we're going to do on Monday actually talks about how information goes up and down the spinal cord. The types of information that the cerebellum uses from our body, like fine touch, pressure, and proprioception, obviously, all of that stuff goes up the spinal cord, staying on the same side that it came in from your body, so that the cerebellum on that side could use it. Then it crosses over so your cortex can have it on the opposite side for you to consciously perceive that information. Everything that you do consciously, up on the cortex. Yeah.
I don't know how much you can tell me, but like how in depth do we have to know these paths? Should we know all these points that it hits, or like just the idea of
All these things
when-
along the way? Not
Yeah.
necessarily.
Just know that when it kind of goes over and
It's
stuff?
bigger concepts will help you a lot more.
Okay,
Like the left hemisphere controls the right body,
yeah,
whereas the right cerebellum controls the right side,
okay,
right? And the cerebellum is using what pieces of information to generate those blueprints to help inform the primary motor cortex to make that muscle action actually smooth
okay.
and not jerky and zombie-like. We've already talked about, you can see, all they're showing you is how the axons are getting out of your cortex, going through that white matter in the deeper parts of your brain. That's a projection fiber. That's coming out of the CNS, right, to other areas. We talked about this thing on the midbrain. Those are those cerebral peduncles, the little things, the feet holding up the brain. That's where those white matter tracts are running through. They make bulges on the ventral surface of the midbrain. And then we saw down here, the pons, remember there's a huge bulge on the ventral part of that? Well, that's where that information is going to be shared with the opposite side of that cerebellum. Because that cerebellum is sitting on the back of the pons, right? Like a little cap. And we talked about down here, the medulla, when we talked about this was the white matter tract bringing that motor axon down. And then at the medulla, this is eventually where the information gets to the other side of the body. That's where the decussation occurs, right? And we talked about that. It's those pyramidal tracts, that's the myelinated axons of those motor neurons now making it to the other side of the body to eventually exit and control those muscles.
I know that in almost every single group of slides that we do, there is something about like diseases. So how do we need to know them well for the midterm, or is that just extra?
Those diseases are largely to put it into context for you. It's the so what component of the class. Like we talked about the pathway, how that information gets down, but then it's so what? Who cares? Well, if you had a lesion in your brain and you wanted to pinpoint it, which is what a neurosurgeon would do before an x-ray or whatever, you look at the symptoms. Have they lost motor in the left or the right side of the body? Is it upper or lower limbs that's affected? Right away they can tell what segment of the brain they're likely going to see the tumor in. That's the reason why we talk about those diseases. And it's sexy too, right? Nobody cares about the normal. Everybody wants to talk about what's wrong. Yeah. Yeah.
Can we go over like the basal ganglia? Like when I looked up lenticular nucleus in the textbook, it came up as lentiform, I think.
Lenticular and lentiform are the same thing, yeah.
Okay.
Tomato, tomato.
Okay.
Yeah. For these structures, I would just think about what components make up that system. So the basal ganglia, which is really inappropriately named, it should be the basal nuclei, because it's a collection of nerve cell bodies in your CNS, not outside of it. We already talked about ganglia in the autonomic nervous system. These are collections of cell bodies outside of the vertebral column in the brain. But think about, what is the basal ganglia or nuclei responsible for? So when you learn motor movements early on in life, you set down those pathways there to help you do things that we consider slow, stereotyped movements that you won't put a lot of conscious effort into. So what we mean is, movements like swinging your arms when you're walking, how you point to an object, how you curl your fingers, that kind of stuff is stored in the basal ganglia because it's learned early on in life. There's not actually a lot of new learning that happens in the basal ganglia. And remember, this basal ganglia, it's helping you to stop motor movements. This is why when we have problems getting the instructions out of there, that we get that disease called Parkinson's, where the people actually, as it progresses, get more and more catatonic. They stay still in the same position for longer, because it's hard for them to, even though they're making the intention to move, to get out of a chair, can't get the instructions out of the basal ganglia. So they can't get that movement started. And once they get it started, they tend to fall over a bit, make awkward movements, because they have a hard time stopping the movements as well to make it smooth. All of these, that motor area there, the cerebellum, they work together. It's up to the cortex which one it's going to depend on more in the end. When we talk about the limbic system, so just think about what were the structures involved and what are the big roles of the limbic system. You should be able to label off 2 big roles that we talked about in this class. Or that they talked about online. That was online, right, for you? Yeah.
Vision? What's that?
Limbic system?
No, that's not that.
It uses some visual input, one part of it. Yeah. So it uses visual input for the amygdala to help analyze facial expression. So that's another part of your brain that's using vision on a subconscious level that you're not aware of. Because it looks for, are they tearing? Are they crying, that person? Should I generate an empathetic emotional response towards that? Or is it someone laughing or angry at me? Should I make a sympathetic response and then get the hell out of there? That's the kind of stuff it's responsible for, right? Fear, rage are the big ones. What is it also responsible for? So what are the components for that limbic system? Limbic just means ring, because the components are shaped in a ring.
You have your hippocampus.
Hippocampus is the big one. So elephants have good memories, but hippos have even better memories. That's how I like to think of it. That's involved in forming memories, right? Short-term and long-term.
So the two main functions of the limbic system are memory and emotion?
Yep, memory and emotions. And because the one component, the amygdala, has outputs to the hypothalamus, this explains why when you're emotional, when you're experiencing fear, or when you're stressed out, the cortex signals down through the limbic system, through the amygdala, to activate the hypothalamus, to generate a sympathetic response, right? So when you're crying, when you're afraid, whatever, you can see a lot of the signs and symptoms that you've activated your sympathetic nervous system. It's all linked together. The diencephalon, those structures, you should know what they are, what their main functions are. The thalamus, the part below it, the hypothalamus, in the pineal gland, that little thing sticking off the back of the diencephalon. The hypothalamus, it looks like it's got a ton of roles, but that huge list that you see there, if you look at it, it's really all autonomic function, almost all of it, right? Controlling blood pressure, controlling respiratory rate, appetite, intestinal motility, all of that is autonomic stuff, right?
For the short-term versus long-term memories, do they all start as short-term memories and then over time as they're repeated, they're long-term? Like as you say, like you're laying down long-term, are they all just short-term and then once you start repeating that response?
So it's up to you. So the frontal cortex talks to the limbic system. When you want to form a long-term memory, you actually consciously make the effort to do that. So for example, when you're studying for the course, a lot of that stuff is sitting in short-term memory, but you're forcing it up into the hard drive, your cerebral cortex, to store it in various different locations as long-term memory. It's like the hard drive of your computer.
Okay.
The limbic system is like the RAM. It only works when it's on. It doesn't work when you're sleeping. So that short-term memory there, that's not entirely true. But anyways, yeah. So long-term memory, so we talked about the different types of memory, right, that you can form. There's 3 types. They get stored in different regions of the body. That's in this slide set too, isn't it? That's not this one, it's the third one, which you guys were supposed to, it's the second one, this one. Is it this one?
25.
Right here. So episodic memory, this is memory of an event that happened somewhere in time. So with events, you have a date stamp that goes with it, right? And the date stamp is performed by, and you can see here, hippocampus. There's also amygdala in there and thalamus. So the hippocampus is the big one for providing a date stamp for memories, both short-term and long-term, right? So where did it happen? When did it happen? And who did it happen with? Things like that get stamped onto those memories. And those memories are all those sensations that were coming into your body. What you saw, what you heard, what you may have tasted or smelled. And of course, what other sensations that came in through your body. Was there pain? Was there certain touches associated with that particular event in time? The amygdala, its role in forming that episodic memory is to give it the switch. Was it a good memory or was it a bad memory? Usually those are the ones that get saved in long term, right? Something that was really, really bad or really, really good. all these stuff in between, it slowly disappears over time. So when you study for the course, make it a good memory. Get together with friends, have a pizza, play some music, and you might remember this stuff. Okay. What about semantic? So what structures does it involve? Pretty much all the cerebral cortex. It's spattered throughout your cerebral cortex in that hard drive. That is just factual information, right? So, I don't know how many lobes of brain there are, stuff like that, okay? You can see that it involves things like the visual cortex, because a lot of what you remember, fact-wise, is something that you've read off a page or seen, happened in real life. Auditory, what someone told you, and somatosensory, so anything that comes in through your body. Pain, touch, pressure, whatever, all of that stuff. And it gets stored out on the cortex. So if you're thinking about where visual memories would be stored, they get stored where they're processed in the first place, out in the occipital lobe. Same with sensations such as pain and touch, they get stored in the parietal lobe, just behind your primary somatosensory area. That's where those memories are kept for long term. Smell memories, there's a smell cortex on the inferior surface of your frontal lobe. That's right where the olfactory nerve is running in to begin with. And hearing memories, you can expect it to be out in the temporal lobe, right? Because that's where the primary auditory cortex is, where you pull apart those neural signals for sound to generate, you know, your conscious perception of those vibrations, that sound. It gets sprinkled throughout your cortex. For procedural, this involves something to do with steps or movements or motions, right? Anything you have to do in a stepwise fashion, like, you know, always save your program before you close it down, that kind of stuff. How to ride a bike, how to play sports, all of that is going to involve, obviously, motor areas of the body. So cerebellum is great for learning new activities and new sports, because it does have a memory area to it, its cortex. And then, of course, they've outlined in purple there the basal ganglia. Really great for those early memories of, you know, how to hold yourself up straight, how to walk on 2 feet, things of that nature. Okay. So obviously your hippocampus, for things like episodic memory, even for this here, some of the semantic information, it's useful in that, even though it's not listed there, but there you go. Any other questions? Is that okay?
Yeah, so the amygdala and the hippocampus are adjacent neighbors, but like how does it actually, like once that response is depicted in the amygdala, how does
They're all connected together.
Okay.
Yeah.
Okay.
So there's connections between them, and of course with the amygdala,
So it's
there's
not
connections
like
that
signals?
flow out to the hypothalamus.
Okay.
So when it's a good experience or a bad experience, you can generate the appropriate autonomic response to that as well. Yeah. All of these are tied together. Remember the hippocampus, the two sides of it, they kind of communicate with each other through the fornix. The fornix is also the way by which your cortex, what you are thinking at that time, what your personality determines, your emotions and such will flow down into that hippocampus. Because remember, emotions are a big part of determining whether or not you're going to store a memory as long-term or forget about it. So like I said, if it's a really good thing or a really bad thing, good chance it's going to stay there for a while. If it's something that really didn't pique your interest, you didn't really care about much, didn't evoke an emotional response in you, you probably aren't going to remember that. Come a year, month even, maybe a week later, who knows. It seems for me it's like seconds. You're watching a TV show that you don't really care about. Yeah. I just don't know what happened in the last 5 minutes. That show. It's kind of like reading your anatomy textbook sometimes too. So be careful of that. These, so all these pathways, the circular stuff, don't get bogged down in this. I would go back to the 3 types of memory, and what these structures generally are responsible for. So that's this slide. Where was it? It was in the next one. That one there. So what are the major components? What's the major functions? Don't necessarily worry about how the information is flowing around to reinforce memories and things of that nature. Because the way it was presented by Dr. Ball, that's just one interpretation of how that information flows around. And because it is a loop, you can start anywhere in that loop. Yeah.
Would we need to know like all the tracks and stuff between like the limbic system, the basal nuclei, and how it gets from like all the specific names for how it goes from one?
I don't think we mentioned many of the tracks. No,
Okay.
we didn't. So don't worry about it. Because there's a lot of association, commissural and projection fibers, tracks that we didn't talk about. The way that the information is shared between them. Just know that the information is shared between them. Yeah. It becomes more important later on when you're dealing with pharmacology. Yeah.
Can we go over like the loop of Pez? Like that?
We could, but I just caution you now, I would shy away from it because it just complicates the whole system.
Then don't go over it.
Yeah. So the loop of Pez is just about you taking a short-term memory of an experience and then sending it out later on to become a long-term memory. Yeah. So it talks about the components, the hippocampus, which is where all that information eventually comes in, right? What you saw, what you heard, what you felt, i.e. touched, not emotionally. But yes, emotions are generated there too with the help of the amygdala. But then it puts a date stamp on it, and then you determine whether or not you want to save that long term. This part here, the cingulate gyrus, that is also associated with forming those memories because it's your reality checker. Was this actually an experience, an episode that I actually have in real life, or is it something that I'm currently dreaming up in my head, pulling down past experiences, past memories, and playing it around in my somatosensory cortex? That's one of the parts that are implicated in schizophrenia, where you think people are talking to you, or you're hearing or seeing things. They're actually not real. They're generated in the brain, but not actually happening out there in reality. It wasn't coming into your body. It's being made up there in the cortex. But that reality checker wasn't working. So you think it's real. So this, going back to the arteries and what kind of symptoms would you expect? So you've got your homunculus for the motor and the sensory, right? Which involves the middle cerebral or the anterior cerebral to cover off the entire homunculus. But you can also think in a general term. That middle cerebral artery does a good part of the temporal lobe, the parietal lobe, and some of the frontal lobe, right? So you can already see some of the things that are involved here in the temporal lobe. Speech, that's understanding speech, understanding language. Your hearing is being processed in the temporal lobe as well. So that middle cerebral artery would affect those functions, right? You can also think about, just in general, what the left side of the body versus the left hemisphere versus the right hemisphere does. And that's what the preceding slides are. The left side's all the logical stuff. Your ability to reason through, make appropriate financial decisions, for example, be analytical and logical. Whereas the other side is, the right side is all that creative stuff, which involves appreciating music, art, being able to do things visually, such as what we call spatial processing. When you see something in 2 dimensions on a screen, your ability to turn it into a 3D image in your brain, that's largely driven by the right side of your cortex. That's part of your artistic, creative function. Okay. Yeah.
So the idea is that all of this information, like of the cortex, is on both sides, if I'm not mistaken, but it's how we take it on either side, which determines like the left side's like the artistic and all that.
Yeah, so when we think about 3D spatial processing, so you do vision on both sides of your brain, right? The left hemisphere does all the processing for everything that you see off in your right visual field, which involves information from both of your eyes, looking off to that side. But when you want to take something that you're looking at and say, hey, that arm that I see, that's actually my arm, or that it looks like it's, you know, X distance away from the object, largely driven by processing in the right side of your hemisphere. And remember, for many people, I think it's about 97%, our language area really driven a lot by the left hemisphere. It doesn't mean that you don't use both hemispheres to hear speech, to see the written speech, and to, of course, form the words with your mouth, because you have two sides to your head. You have to move both muscles. It's just that most of the processing to understand what you're hearing, what you're seeing as speech, and turn it into a language that you can understand, driven mostly by the right side. So that means that information on the right side, on the left side, is driven by the left side. That means that, because that's the logical side, that means that, you know, when you're seeing things, when you're hearing things, it's being shared from the right hemisphere to the left hemisphere and vice versa. That's why we have a huge tract between the two hemispheres. Those commissural fibers, the corpus callosum. Yeah.
So could something like your emotions or problem solving be affected by both the, like either the anterior or the middle cerebral artery? Or,
That's a
like,
good
where do
question.
they stand?
Yeah, so we might not ask questions of that nature. But yeah, with those deeper nuclei, remember there is two halves to them. The middle cerebral supplies blood to much of the deeper structures of your brain, but so does the posterior cerebral. It gives off some deep branches that go in towards the back of the brain there. So it catches the tail of the caudate, catches the tail of the hippocampus as it's curling around. So it's actually supplied by more than one blood vessel, those structures. So we tend to shy away from those. It's not one where we can say it's definitely this or that.
I'm a little confused on like the functions of the caudate and like, the lentiform nucleus.
So don't worry about those.
Okay.
Yeah, just know it as the basal ganglia. And then it's involved in starting, stopping motor, and storing some really early motor experiences that you're going to continue with the rest of your life. So we all pick up habits, you know, how we hold ourselves, the kind of gestures we make. We form these really early on in life. Different types of neurotransmitters? It's a good idea to know them, yeah. We've discussed most of them already. Acetylcholine, the catecholamines, they're the big ones, right? There's other biogenic amines that we talked about too. I think serotonin and histamine. Everybody should know histamine, allergies. It's also necessary for you to stay awake. It's part of that arousal system as well. Not mentioned in those slides with the reticular activating system. It's a different system that does that, but the whole reason why if you take an antihistamine you start getting drowsy. This histamine in your CNS keeps you awake. Knock it out and you can't stay awake. Yep.
So I was confused on like the classes. So like acetylcholine, like those are the four cholinergic or whatever, I can't say it.
So acetylcholine, cholinergic.
Cholinergic.
Anything that's using it is considered a cholinergic system.
So like that's a class, and then like the biogenic amines,
Yep.
and then the amino acids and peptides. Are serotonin and histamine like their own classes, or?
Serotonin and histamine are part of the biogenic amines.
Oh, okay.
Yeah. It's just that under biogenic amines, you have a class that are together, the catecholamines, that are built in a stepwise fashion. You get dopamine first, then it's epinephrine, and then norepinephrine through different enzymes that convert one into the other. Yeah. But they all have, because they're biogenic amines, an amine functional group at one end of the molecule. And biogenic just means that it has, or it can create biological responses in tissues. Yeah. Bio, life, genesis, to create. So it creates a life function. Yeah.
Can you discuss the effects of the sympathetic and parasympathetic?
So sympathetic and parasympathetic, whenever you come across those questions, I would start with your 3 Fs in your SLUD, and then try to predict what you'd expect to see in that system.
On the heart?
So on the heart, what would you expect in a flight or fright response? Does the heart go to sleep? No, it wakes up, right? So increased rate and contractility. There's also blood vessels that supply the heart. Is a good time, that time, to constrict when it's flight or fright? Probably not, because that would be strangling the heart and you die. That's a myocardial infarct, right? You don't want to have one every time you're excited. So you dilate those vessels. Now, where don't you need blood when you're flighting or frighting? Your intestines, right. You also probably don't need too much in your skin at that time. If you need that 8% of your total body blood volume, you can take it out of the skin. That's why everybody looks kind of a bit whitish when they're a little frightened. They're sympathetically driven. Until, of course, they've been running so much that they've built up heat. Then we got homeostasis kicking in, right? Dilation of cutaneous blood vessels to get rid of that heat. You look red, like a lobster.
Blood vessels are like mainly controlled by sympathetic innervation, right? Which is like the alpha or whatever.
Exclusively controlled.
Yeah.
One of the few examples.
Yeah. So then how does it also constrict with the sympathetic, or what constricts it? Because doesn't the sympathetic die?
So remember the effects for the sympathetic nervous system, those neurons are going to release epinephrine or norepinephrine. The effect it's going to have on the target organ depends on the receptor that target organ has. Is it going to be a beta receptor? Is it going to be an alpha receptor? That tells you what's going to happen to that target tissue.
So beta would be like increased heart rate, and then alpha would decrease, or is it the opposite way around?
So in the adrenergic system, epinephrine and norepinephrine, we have beta receptors and alpha receptors, right? That there's also subtypes. Beta 1 and beta 2, right? Beta 1, you have one heart, so that mediates most of the effects on the heart. The increased heart rate, increased contractility. What do beta 2s generally do? They stimulate, not contractions, but relaxations, right? So beta 2 is in the lungs, you relax your airways, right? Beta 2 is in other tissues too, not just the lungs. The example we gave in the class was the uterus. At that time, you know, if you have a baby in the uterus, do you want it contracting at that time? No. It actually relaxes it. Beta 2 is also present. How do we get the blood to flow to the skeletal muscle? You have to dilate the vessel, right? Beta 2 receptors in those blood vessels servicing your skeletal muscle. And of course, beta 2 in the coronary circulation. Got to dilate those vessels. So it makes sense, right? When sympathetic gets activated, there's blood vessels that have alpha receptors on them, right? They will constrict in your skin, in your gut, because you're not using those organs at that time. But then you have to have beta 2s in other areas where you want the blood to go. Skeletal muscle and the heart are the big ones. Not the only ones, but the big ones. Does that make sense? Beta 3, no. It's one of those weird ones. Just like alpha 2. Central nervous system, platelets, things like that. Yeah, go ahead.
So why doesn't the parasympathetic nervous system have the adrenergic receptors? Like, why don't they
Parasympathetic has the cholinergic, right?
Yeah, I know, but why don't they? Like,
Why don't they?
so like
If they did, they'd be having sympathetic effects, right?
I think of like noradrenaline, so then I think of like relaxing. No?
That's adrenergic. Adrenaline and noradrenaline are the same as epinephrine and norepinephrine. They're just a different way to say it.
So the parasympathetic nervous system doesn't ever need adrenaline. acetylcholine. It
only uses acetylcholine, period. Yeah. So the only exception, so we looked at the somatic nervous system and the two branches of the autonomic nervous system. Guess where acetylcholine's found? In all of those. The somatic nervous system, for us to control our skeletal muscle voluntarily, uses acetylcholine. But it binds to, on the skeletal muscle, a nicotinic acetylcholine receptor. In the parasympathetic nervous system, the postganglionic fiber, the one that's going to go touch the target organ, releases acetylcholine too, but its target organ has muscarinic receptors on it. That's how we separate autonomic stimulation from somatic stimulation at that level. Sympathetic nervous system uses the catecholamines, epinephrine, norepinephrine, or if you like, adrenaline and noradrenaline. Has to bind to adrenergic receptors, right? But remember, acetylcholine is also present in the autonomic system for both sympathetic and parasympathetic because the preganglionic fibers going into the ganglion are all releasing acetylcholine. The postganglionic fibers express which cholinergic receptor? Is it muscarinic or nicotinic? There's only two you can choose from. It's all right. The room's full of nurses. Do you know? Don't stick your hand out.
Can you say it again?
So what happens when you smoke? Why do you get sympathetic and parasympathetic effects at the same time? Because it's nicotinic receptors on the postganglionic neuron that are being stimulated in both systems. Draw that picture in your head, the two neuron circuit, and label where those receptors are. That's in the autonomic nervous system lecture. Good way to differentiate between the two. So you have the increased intestinal motility, you got to take a poo in the morning, and you get the sympathetic effects. Wow, I'm awake. It's all in the cortex, epinephrine, norepinephrine being released. And heart rate going up. Now we didn't mention alpha 2s, their big job, but it's in your slide set. It increases clotting. So whenever you smoke nicotine, you get catecholamine release. Guess what you're doing to your blood? Making it a little more sticky. That's why people have a heart attack in the morning. After that smoke. Other questions? So we do test right from the start. You realize that, right?
With the slide where it shows the MRI of the hydrocephalus, on the meth anatomy, it explained how it asked what the stenosis is, and it said it was a cerebral active. Can you explain what it is?
This one here?
Yeah, because see how it says with the lateral ventricles and the third ventricles, he said if they were dilated. How do you know that they're dilated just from looking at it?
So I wouldn't ask you to look at a picture and analyze that. Because I don't expect you to be an MRI tech.
Okay.
It will all be in the words of the question, if we have a question on it. Right? So this one, in the explanation, so if you saw the video, you would have seen a little mouse going around too. In this hydrocephalus person, they're showing that's the abnormal. There's what it normally should look like. Both lateral ventricles are really big. Cutting down further through the vein, this is the third ventricle. It looks like a slit, right? Because it really is a thin wedge between the two halves of your hypothalamus and your thalamus. It's sitting right between them. Here, it's widened up. It's a bigger hole now. It's this hole right there. And all he was saying there, so he described it verbally, was that lateral ventricles are increased, third ventricles increased, but fourth was found to be fine. So if there's fluid building in 1 and 2, and number 3, there has to be an obstruction to the flow of CSF in the next structure where the CSF would go, right? Which is to get to number 4. Number 4 is fine because the little tiny holes on number 4, they're still there. And they're letting the CSF out to the outside surface of the brain. Right, subarachnoid space. So that CSF, remember, it's made where? Choroid plexus, which is located in the ventricles, right? So it's formed on the inside of the brain, inside the tube. Gets outside surface of the brain. How does it go back? Where does it go? Speak up.
What'd you ask?
Where does the CSF go?
From where?
From this subarachnoid space on the outside surface of your brain.
To the body. Through the sinuses.
Right, the venous sinuses formed by your dura mater. So there's a big one, superior sagittal sinus, that forms between the two hemispheres of your brain and the falx cerebri. And then remember there's a tent that goes over the cerebellum. That's a dural extension as well. Well, guess what? You make a sinus in that dura as well. So it's bringing the blood from the top of your brain over the top of your cerebellum. Then it takes a turn, the sigmoid sinus, to go blunk into your jugular veins and get out of your skull. So the blood came up from the bottom, circle of Willis, got drained from the top to go back down your jugulars. So you made CSF by taking blood plasma, ions, glucose out of the bloodstream, throwing it into your ventricles. But if you took it from the blood, you better put it back because you can't make new matter. You can't destroy the matter that's already there. You have to return it to the blood. That's where it goes back.
So there's those granulations in both like the transverse and the sigmoid sinuses too. So it's just taken in from all of them.
Yep.
Okay. And that's all from the sigmoid.
Yeah, arachnoid granulations, a little broccoli. It kind of looks like broccoli there. See? So tasty. So you can expect to find those arachnoid granulations in all the sinuses, the dural sinuses that are carrying venous blood away from the brain. It's really warm in here. I'm radiating heat. Yep.
Can you talk a little bit about skin glands?
Skin glands, you're not going to be tested on them. Because we didn't get to them in lecture, and that's fine. We didn't last year either. I don't know why we didn't change that. It was there for your interest as an essay question. It's good to know that you have ones that create watery substance versus ones that create fatty substance. Fatty ones are really good for keeping your hair nice and shiny. You wash that natural conditioner away every day, and then you put fake stuff on. Exactly. And then your hair gets too fluffy. Any other questions? Yeah.
Can you just go over the role of like ATP in the contraction cycle of like just when it, I'm just confused of when it's splitting into the ADP and phosphate and then like I know a new one comes back in order to minimize.
Yep, so the, I guess it doesn't matter where you start, but I guess the best or logical place to start is when myosin is bound to actin already.
Okay.
It's stuck there, can't let go, right? Until a new ATP binds to it.
Okay.
When the new ATP binds, it can let go of actin, and then what's going to happen is the ATPase in the myosin head breaks the ATP down. Because you've broken the ATP down, there was energy stored in that ATP. Gets turned into mechanical energy in that myosin in the fact that it changes its shape. It becomes cocked, just like a trigger on a gun, right? This cocking also allows it now to go up and grab actin. And as soon as it binds to actin, again, another shape change because it's going to transfer the energy from the ATP now from the myosin head into actin by doing that power stroke. moving back to its original shape, but the ADP is still bound to it, and it's still bound to actin. Can't let go until, again, ATP comes along, and then it can let go.
So when does the hydrolysis occur then?
A hydrolysis occurs as soon as that ATP binds myosin.
So before it's cocked or?
Right before it's cocked, yeah.
But then,
It should be, so let's go to that, let's go to that.
so then the ADP and the phosphate is still there. So how does it get the energy?
They dissociate when ATP binds. Because they have to bind to the same region of the myosin ATPase that the old ADP was sitting in. So as soon as ATP is hydrolyzed, as soon as you get rid of the phosphate disappears, it just dissociates. And ADP is still bound to the myosin until a new ATP knocks it out. You'll talk more about that in biochemistry in the winter semester. So joy. See here you got ADP. That phosphate is really dissociated now. They still draw it there just to show you that there's inorganic phosphate there now, but that's the last phosphate on the adenosine triphosphate that got cleaved off. And there's energy in that phosphate to phosphate bond that's being transferred to this myosin. Okay. So here is, see, now you can see ADP still stuck to the myosin head, still stuck to actin. This is where it's gone through the power stroke. Now that it's gone through the power stroke, you can see here it shows that ADP actually dissociates once that conformational change occurs. I'm not really too concerned if you know when ADP falls off of it. That's not the big deal. The big deal is ATP. Providing it with energy to change its shape, allow it to grab onto actin, and then do the power stroke.
The question is, how does it get the energy to rotate towards the center of the, like how does it get the energy for that power stroke? Because the ATP has already been used.
So there is, you get cocking of the myosin, right? So the energy is being stored in that myosin there. As soon as it touches the actin, that fact that you're forming a bond between two proteins, again, allows the energy transfer to occur. So it's going to allow the myosin to go back to its original conformation. The energy has now been put in actin because actin has actually been physically moved in space and time. Just think of it that way. I know, it's probably still not clear. ATP gives that myosin head energy to be able to grab onto the actin and then pull it towards the center. Just think of it that way.
So I know how anti-cholinesterase works. Like you can't break down the ACH and you get all those parasitic effects, right? But what's like the antidote? Is that the neostigmine or something? So how does that work exactly? Like as an antidote?
It blocks the receptor, this acetylcholine receptor.
Oh, so you don't.
But if it's for parasympathetic effects, that one's not for parasympathetic effects, is it? Neostigmine?
Isn't it for sympathetic? Because then it causes a buildup?
That one's for the somatic nervous system, right?
Yeah.
Yeah. Are there any questions? We'll go to that, but are there any questions related to this muscle contraction cycle still? Yeah.
Part of the ryanodine receptor that's inside the sarcoplasmic reticulum, is it attached to the terminal cisternae that like stores the calcium, or is it just attached to like the sarcoplasmic reticulum in general?
So you see here, that is the blue part there. That's the terminal cisternae. That's the bulge at the end of the sarcoplasmic reticulum that holds the calcium. That ryanodine receptor is an ion channel sitting in the plasma membrane, allowing the calcium to flow out when that dihydropyridine receptor that's stuck to it moves, because it pulls the plug out of the ryanodine receptor, opens it up essentially. So you'll notice that these have to be set up in space in order for that to work, right? The SR has to be right beside a T-tubule, so that these two proteins, one on the T-tubule, one on the SR, can actually touch each other and have an effect on one another. Right? So it's very intricately designed, that system, to make an action potential move one protein, the DHP, which is then stuck to another protein that causes it to open up and let the calcium out of the SR. So when the action potential goes away, plugs back in the hole for the ryanodine receptor. No more calcium release. So it comes out and bursts, the calcium. To get a lot of calcium in the cytosol, to make a really strong contraction by getting more of these cross bridges forming, you need lots of action potentials hitting that muscle, right? Very close together. So you keep release calcium before it has a chance to be pumped back into the SR. That pump is always going in the background like the sodium potassium ATPase is up on the surface, right? But that pump is kind of slow. And that's why if you get a lot of release events occurring at once, the calcium levels rise in the cytosol and you get a really, really strong contraction. Because calcium binds what, which moves what, and allows myosin to touch actin. You should remember that. How does it regulate it all? Yeah, this I always found myself a little confusing, that whole contractile cycle. Where is the energy at any given point in time? I would just put it in simple forms. ATP gives the myosin energy, and then the energy is transferred to actin. So there was a question of neostigmine, right? Neostigmine. Actually, neostigmine is an anticholinesterase, isn't it? Yes, it is. It kind of acts like nerve gas. Yeah, that's how it works.
Is the nerve gas?
So neostigmine is a form of an anticholinesterase that they use that's, I believe it's specific for the anticholinesterase that's found in skeletal muscle only. Because there's slight variations in that enzyme. So they use it in people who have the disease myasthenia gravis, where they have a problem with, in their skeletal muscle, the number of receptors for acetylcholine is going down. So anytime they send a neural signal there and there's acetylcholine release, there's not enough receptors to stimulate the muscle cell. So they give them that drug so the acetylcholine that's released doesn't get destroyed. It can build up in the synapse and stimulate all the receptors that are left there on that muscle to get a contraction going.
So then how do you cure that? Like if it was the opposite way?
That is a cure for a disease, actually.
Yeah, but how do you cure it if you have like?
If you have too much acetylcholine,
Yeah.
you can put a blocker for the receptor in there.
What should be called?
An acetylcholine receptor blocker, otherwise known as
And it does it start with an A?
a cholinergic antagonist, you could call it. Yeah. As opposed to, we have cholinergic agonists as well, so they actually have the cholinergic effect. We can make synthetic acetylcholine and give it to someone just for
You said the neostigmine, it allows the buildup of AHC at the
ACH, yeah?
ACH, sorry, at the receptors. But at what point does it know to, like,
It doesn't.
it doesn't?
Yeah. That's why when you're on that medication, you see your physician at regular times, just to make sure that A, you're not getting too much of it, or if you need to, they can increase the dose to get you more acetylcholine so you can get more muscle function back. In the past, you used to have an essay question about it, but we don't talk about it in lecture anymore, so we don't do that. Yeah.
In the ANS lecture, when there were the eye-clicker questions like actually written in, could you just go over a few of those?
That one there?
Yeah.
So this one's the question about which branch of the autonomic nervous system in this organ that's dual innervated is predominant. So is it going to be sympathetic that's predominant, or is it parasympathetic? For the heart, it turns out the answer was parasympathetic, right? So your heart is always being slowed down at rest by the parasympathetic branch. Both are always there, they're always stimulating the heart. It's just that at certain times one gets turned up, the other gets turned up. So during a flight or fright response, sympathetic would get turned up so your heart rate can increase, right? We know that parasympathetic is dominant at rest because if you took all the input away from the heart, what happens to the heart rate? The heart doesn't stop, it keeps beating. Because it generates its own rhythm, right, with its pacemaker cells. And they generate that rhythm at a rate of 100 beats per minute. Our normal resting heart rate is 75 beats per minute. So it tells you that there's always slowing down of the heart at rest. When you're exercising, it's a different story, right? You got sympathetic stimulation going on, and the heart rate's going up.
So in this case, it would just be
So increase in heart rate and blood pressure. So A. A is the correct answer for that question. We just answered this one. B for that one. Because at rest, parasympathetic dominates. So there's more parasympathetic than sympathetic input. And parasympathetic is turning the heart down, making it work less efficiently, because at this time you're resting and relaxing, right? You don't need to have your blood pressure through the roof because you don't need to send that blood to your skeletal muscle.
Sorry, I missed the answer for the last question.
It was A.
A?
Increase in heart rate, increase in blood pressure as well.
In the lecture, we had the answer B.
Sympathectomy were performed. Oh, wait a second. We're doing just the sympathetic. We're taking it away. Sorry. Yeah, you only have parasympathetic effects. That's B. Yeah. Sorry, I have to read the question. So, a lesson for you. This is what I see a lot. Read the question on the exam. 9 times out of 10, that's why you selected the wrong
The other one is
answer.
just because like we're taking it out, so you're taking away mostly parasympathetic, right?
Yeah, the other one is you're taking it all out, so and it's mostly parasympathetic at rest, so you're having a net increase in heart rate. Yeah.
Why does the force of contractions increase though?
Parasympathetic, its job is to A, reduce the heart rate, and also at the same time reduce contractility. So get less calcium into the muscle so it's a less forceful contraction, because you're resting at this time. When the heart has to work harder to generate more force, to make a more forceful contraction, it also consumes more oxygen. So it needs more blood flow itself. You only got one heart, you gotta keep it around forever. Burn the candle at both ends, you die sooner.
Can you go over graded potentials a little bit? In like
Sure.
the second-
Do we want to go through the others that were in this
Yeah.
one first? Okay, we'll go through. So some organs only have one type of input. This was the question related to that. This is the example of a system where there's only sympathetic input, right? 2 blood vessels. Notice that it says peripheral blood vessels, so these are the ones in your skin, in your gut. They're considered the peripheral blood vessels. So if you took away the autonomic input there, hey, it's the only one that's right. Vessels would dilate because there's no sympathetic input to maintain vascular tone, and the blood pressure as a result would drop. This one's about the eye. So atropine from the plant Atropa belladonna, it blocks muscarinic cholinergic neurons, right? It should say muscarinic cholinergic receptors. What would this drug do to the pupil? So parasympathetic normally does what to the pupil? Make it bigger or smaller? Make it smaller, meiosis. If you can't do that because you blocked it, the only way the eye can go is get bigger because there's only sympathetic input to it now. And the sympathetic system pulls it open through the radial muscles there on the outside as opposed to the sphincter muscle around the inside. So, we talked about this one already. Inhibit the anticholinesterase, which is responsible for breaking down acetylcholine. Anytime it's released, you're going to get cholinergic effects. And the only one that's a cholinergic effect is meiosis of the pupil constriction. Okay, that was all those questions I think in that one, right? The other question was about...
Oh, sorry, yeah. Greater potential.
Greater potentials. That's from membrane potentials.
Can I quick ask something about, back to what we were just talking about?
Sure.
For the ganglia, when it says, like, they're all in the head after all, what does that mean? So, like, most of them...
That's for the parasympathetic nervous system, right?
Mm-hmm.
Where it shows a diagram, the cranial nerves from your brainstem coming out of the skull. Well, it shows it coming off of the brain, and then it shows a picture of the head beside it with it innervating glands, and that your glands are all here.
Yeah.
The cranial nerves are coming off your brainstem. It's all in the head.
Okay.
It's not
I'm
coming
thinking that
outside your
question's
body
totally
and
wrong.
swooping back.
Okay.
It was a point for a joke. The wireless cranial output, because it goes into space, comes back, and wirelessly controls all your salad. Doesn't happen. Graded potentials are just tiny little changes in the resting membrane potential that are brought about by ion channels opening, right? So these ion channels are specific subtype, right? They're the ligand-gated ion channels. Something binds to them, a neurotransmitter, opens them up, and you get a small change in the resting membrane potential. It's not very exciting until that small change in resting membrane potential hits the threshold, and you can make an action potential. Yeah.
So are the ligand-gated channels in any way related to, like, a chemical synapse? So are those the same type of receptors that, like, acetylcholine would bind to? Like, they
So
bind to
acetylcholine
ligand?
receptor is a ligand-gated ion channel that happens to let sodium flow into the cell.
Okay.
Yeah.
So then in that case, they could cause an action potential? Okay, but in the case of graded potentials, then they'll...
Well, in that case, they're still making a graded potential in the target cell, right? That acetylcholine receptor, because that's a ligand-gated ion channel. Making a small change in the resting membrane potential is another set of channels that has to open to make an action potential.
Oh, okay.
Which are the voltage gated, right? Because they don't open in response to a chemical, they open because the graded potential is changing the resting membrane potential. Enough that that channel can open now.
Okay.
They're the ones really that are making the threshold, right? It's the property of the sodium channels, the voltage-gated sodium channels, that say that I only open at minus 55 millivolts. If it's less than that, if it's more negative than that, I'm closed, period. So there's no action potential. Yeah. Could do a whole course on ion channels. That was my PhD. I'd sit in a microscope and measure tiny little currents across individual cells. Mind-bogglingly fun. These guys, voltage-gated ion channels, so a graded potential is going to change the membrane potential there, the resting membrane potential. If it gets to the threshold, that guy can open.
And then all of the sodium would rush in from the outside, or has it already started to rush in because of the...
We had a ligand-gated channel, the acetylcholine channel,
Yes.
that's allowing a little bit of sodium to trickle in, right?
Yeah.
To change the resting membrane potential. This guy opens up and boom, a whole flood of sodium can come in.
Okay.
Makes even bigger change in the resting membrane potential, which wakes up all the other voltage-gated sodium channels in the vicinity,
Yeah.
and you get, boom, positive feedback, right? Because then more of them open up, and then all of a sudden they're all open. You've got a huge reversal in the resting membrane potential because all the sodium came inside to the inside, made it positive.
Thanks.
That's your action potential. Yep.
I have a question about those ganglia again. So for sympathetic, you have the chain ganglia and the collateral ganglia. Is the collateral just that it doesn't synapse with those ganglia in the chain, like it keeps going, the presynaptic
Yeah, so
neuron?
it's in the, you know that the sympathetic nervous system has to activate the whole body, right? But the nerves only come out of your thoracic and lumbar region. Well, you still got your head to worry about. So you need to send ganglia up your neck, and those are the collaterals.
Just those ones?
I think there's some others, big ones that are sitting right at the big vessels servicing your abdominal
Yes.
organs.
So the purpose of that is just to go farther out into the body?
Yeah.
So why do they want a farther pre-ganglionic neuron? Why don't they just have a farther post? Okay.
I didn't make the system up.
Well, I don't know if there's a reason.
No, there's no reason for it
Okay.
that I can see.
It's just how it is.
Yeah. It's just how it is. Let's stick with that. I like that explanation. Yeah. Any other questions on that kind of slide set there with the membrane potentials? No? Okay.
For the cranial nerves, should we just focus on like trigeminal and like vagus because those are the ones that would be really touched on, or should we focus on like?
I would focus on the ones that we mentioned along the way.
Okay.
Yeah. So we did mention the vagus nerve. We did mention the trigeminal nerve in some of its branches. Did we mention any others? The optic nerve, you know that that's for vision, right? Cranial nerve number 1's for smell, because we talked about smell memories using the mammillary bodies, otherwise known as memories. Vestibulocochlear nerve, yeah. Because we have vestibular input to the cerebellum, so cranial nerve number 8, you should be familiar with. It has those two components, balance for the vestibular branch, and then the cochlear branch, that's the specialized organ that allows you to hear. So there's two parts of that cranial nerve number 8. Used to be just called the auditory nerve, and that's how it is in that rhyme that I gave you, realizing that it does balance as well, right? Vestibulocochlear is its actual name. Very descriptive name based on its function. Is there any others that we talked about on the way? Not sure. I think that's it. Until we got to vision, and then it was a whole bunch of other ones.
You want to review stuff that you think is super confusing and
Nice try.
I think you got most of it. Most people tend to be freaked out about the central nervous system. If you keep it to the simplest ideas possible, like what does the basal ganglia, what does the limbic system as a whole do, that should help you through most of it, probably.
I don't know if you can answer this, but like, will the questions be more like eye clicker questions or like quiz questions? Because there's like a big difference.
A mixture. So there's straight fact recall questions. Maybe a third of them are going to be the application style questions. You know, things based on symptoms, or if you broke this part, what would happen? But they're all multiple choice. There's only one correct answer for each of them. There's none of this. Is it A and A and B? Or is it C and D? No, none of that. It's one correct answer. So we actually say choose the best answer because in many cases, well, not many cases, in a few cases it may seem like there's another option, but really that's not correct either. And there's a bunch of reasons why we can say that. We will explain it when we take it up. We take it up 3 weeks after you write it. We have to give an opportunity for folks who missed the midterm to write it. We don't want the answer figure skating. Okay. Good luck, guys.